I'm Scott. I'm presenting my project today, whose title I've shortened to a 3D dosimetric investigation of CyberKnife tracking method accuracy to kind of remove the fluff. Oh, that's not working. Great. There we go. So the primary aim of this project is to expand on work done previously in 2018 to 2019 by someone named Thomas Klein as part of his master's project. Unfortunately, this project wasn't able to be published, so the aim of this is to expand on that and produce a paper that's clinically relevant, and thus is able to assist clinically in the choice of which tracking modality to use for CyberKnife. Another aspect of it is to create a novel 3D dosimetric approach to CyberKnife to allow for potentially further quality assurance in other centres. So as a bit of background as to the focus of this project, lung cancer is the 5th most commonly diagnosed cancer in Australia per year. But despite that, it's always the leading cause of cancer deaths in Australia, which is caused by its only 80% overall 5-year survival rate. The majority of these cases are non-small cell lung cancers, which are typically treated with surgery. However, for elderly patients or those with a compromised lung function, surgery isn't always an option. So for that, we can turn to radiotherapy as an alternative form of treatment. When doing this radiotherapy, though, there are numerous considerations that we need to think about. So for one, the lung is very radiosensitive, and it's also in constant motion due to respiration. In addition to that, the heart and the spinal cord are also in very close proximity. This means that when we're performing radiotherapy, we need very high dose conformations while maintaining that high level of dose to the tumour in order to actually cure it. So this has led to the implementation of stereotactic ablative radiotherapy, which is also known as stereotactic body radiotherapy. So this is a method of external beam radiotherapy that really highly focuses on that dose conformation while maintaining a high dose, and it specifically only uses a few fractions compared to more conventional forms of therapy. As a note, it's distinguished from radiosurgery in that it's only focused on extracranial tumours, so it doesn't focus on the head or the spine. When we're talking about the SABR of lung cancer, because of the high level of dose, we really need to minimize those errors to ensure that we're not dosing healthy tissue. We can attain this through the use of image-guided radiotherapy. However, we also need to account for the motion. And there's numerous techniques that I've listed on the right-hand side there for accounting for this motion. Each has its own disadvantages. While they're still valid methods, there is real-time tumor tracking. This allows for a really highly accurate dose confirmation and a high level of dose. It notably doesn't require the patient to restrict the breathing, and it doesn't overly dose the tissues around it by adding an internal tumor margin. So it's really one of the gold standards for treatment. And the way we can carry out this treatment is using the CyberKnife system. So if we look over at this, we have a linear accelerator head, which is a 6 MV linear accelerator on top of a robotic arm. And coupled with that are 2 X-ray sources and 2 flat panel detectors. So this is what allows for the real-time imaging to occur during treatment. If we look down here, we can see the robotic arm has 6 degrees of freedom, which means that it can effectively beam the target from anywhere around the patient to anywhere in the patient. And that it means it's a frameless system. The 2 orthogonal image providers can image clinically as frequently as 15 seconds, although different frequency periods can be used. However, as you may imagine, we breathe far more frequently than every 15 seconds, so that's not actually what's used to track the tumor motion. We instead use something known as the Synchrony system. So this system uses optical markers on the patient. We can see the vest here. This is linked to a camera array. And immediately prior to the treatment, 8 X-rays are carried out whilst the patient breathes. And so we can track the motion of the optical markers, we can track the motion of the tumour, we can establish a correlation model between the two. So instead of continuously tracking the tumour using X-rays, we continuously track it using this optical markers on the vest. However, in order for this to be useful, we need a really quick and efficient way of delineating and targeting the tumour inside the body using only those X-ray images that we take to update the model. One such method is fiducial-based target tracking. So this, we typically implant a high Z, which is a high contrast marker. Typically it's gold. And we implant these around the tumour location. And we take the centre of mass of these fiducial markers to be a substitute for the actual tumour location in the body. Typically, we use at least 3 because 3 are needed to account for the rotation. However, more can be used. Unfortunately, this does come with a risk of pneumothorax, which is lung collapse. So if you're inserting something into the lungs, there's a chance that you'll have lung leak into the space between the lung and the chest wall. And for patients that are already suffering compromised lung function, that's obviously not ideal. The markers can also sometimes be subject to drifting from the implanted location, which leads to inaccuracies in tumor location. So as an alternative, we have the Xsight lung tracking system. So this compares the images taken by the orthogonal X-ray imagers to the planning CTs, and then it compares using intensity pattern matching algorithms. As you can see on the right there, this is the planning CT, this is the X-rays taken during the treatment, and then it can overlay them and match the patterns. This doesn't require any fiducial markers, which is obviously a benefit. However, it can only be used if there's a high enough contrast to actually visualize the tumor with just looking at the X-rays. Typically, the manufacturer recommends above 1.5 centimeter diameter. However, studies find that for an 80% chance of accurate visualization, you typically want above 3.5 centimeters, and you want the tumor to be dense enough to be adequately visualized. So we have 2-view, where both of the imagers can visualize the tumor, which gives 3D positional information. Sometimes that view might be blocked by the ribs or any other sort of interfering object. That can be known as 1-view in the case where only one can visualize it, or no view. This uncertainty means that we need to add margins in the dimension that's not being adequately visualized in order to account for it. So this is the literature review I've done. I just wanted to give an overview. So these are all specifically dosimetric studies of the CyberKnife system, and some looked at Fiducial and Xsight. This is a particularly important one. A lot have looked at the individual ones. However, you'll note that there's essentially no 3D studies. Most use a 2-dimensional film study using a moving phantom. The only one I could find is from this year, published in April, which is looking at the use of a quality assurance gel dosimeter in patient-specific QA. It's obviously very recently published and there's not much follow-up to it. However, it kind of highlights the fact that there's pretty much no 3-dimensional dosimetry of the CyberKnife tracking methods being done. So that leads to the motivation for the project, which is by providing this data to clinicians, it's another piece of data that they can use in their considerations of which tracking method we want to use. Specifically in the case of 0-view and 1-view Xsight, where only one or none of the X-ray imagers are able to visualize the tumor, we still would like to use these because it doesn't require fiducial insertion. So knowledge of whether these are providing a high dosimetric distribution is very important. So like I said, it's not really discussed in very many papers. 2-dimensional is common, but that doesn't capture the full breadth of a dosimetric distribution. Finally, the 3D, as I mentioned before, the 3D dose reconstruction method could potentially be utilized in further QA analysis in other centers. So in order to carry out the study, we'll be using the Quasar Phantom. So this is a cylindrical phantom meant to mimic the patient torso. It has a motor that moves a cylindrical insert in an inferior superior motion, and it also has a chest wall platform that moves in an anterior posterior motion. So we can insert 4D CT scans, respiratory data from patients into this to mimic real patient breathing. You can see the cylindrical insert also comes with a tumor equivalent material in the middle in a sphere, and either half of it, one half is lung inhalation equivalent and one half is lung exhalation equivalent. We can then insert radiochromic film between these two halves in order to carry out a dosimetric study. However, we need to make modifications to this to make this study 3D. So instead of using the typical phantom, we can use a pipe filled with alternating layers of film and corrugated plastic. So this allows us to basically carry out a 3-dimensional study using each of these 15 pieces of film and then correlate them together. In addition to that, a spine needs to be added, a bone equivalent one, typically 3D printed, because the Xsight system uses the spine location in order to enhance its accuracy, and that's kind of the main leading accuracy method for the 0-view system. And in addition, in order to mimic that blocking of the site from one or both of the orthogonal X-ray imagers, we need to add bone equivalent ribs that can potentially get in the way of the motion. So these are the 9 treatment plans we'll be using. Synchrony just means whether it's moving or not. So we'll be doing static ones as well, just as another point of reference to view how motion changes it. Some will have rotation of the cylindrical phantom allowed, which will add another degree of potential error, which we can then account for in our dosimetric studies. We'll again be comparing 1 fiducial versus 3 fiducial, and then the full 2 views versus the 1 view versus the no view. So once we have the film for all of these treatment plans, we can scan it in, and then a MATLAB code can be written that converts it into this sort of 3D dose distribution you see here. And then we carry out, after we've got distributions for every single one of these plans, we can carry out a quantitative analysis. And that's known as a gamma analysis. So this is a method of quantitatively comparing a planned dose distribution to an actual dose distribution. And it uses both the distance to agreement and the dose tolerance to calculate a gamma value for each point. And then it gives each point a pass or fail. So if it doesn't fall within the tolerances, so a typical tolerance would be something like 2% dose within 1 millimeter. If it doesn't pass that, it's counted as a fail. And you can get an overall passing rate for a dose distribution compared to the planning distribution. And that gives us a quantitative analysis of how accurate the dose distribution is to what we planned. So this is my current study plan. So the first step is going to be the preparation, any sort of modifications we want to make to the phantom or the method as described in the initial Thomas Klein's project to maybe remove some of those problems that were had, along with developing the software and getting hold of those treatment plans. Once we have that, we can then move forward to carrying out the plans with the CyberKnife. This is likely going to be the most labor-intensive part of the project just because it is an insane amount of film that needs to be had for each measurement. So that's why I've got both these hours here, because I'll likely be doing these 2 in tandem. I'll be getting measurements, scanning them in and looking at them, then getting more measurements. With those measurements, I can convert them into the dose distribution, modifying the software that I've written as needed, because software always has issues. And eventually, once we have all of the data, we can perform that gamma analysis, obtain that quantitative results, and then hopefully make some clinically relevant conclusions about the dosimetric distribution for each of these tracking methods. And that's my references. Cheers.
I was just wondering, with the so you're going to have sequential pieces of film,
Yeah.
right? But you're planning to create a fully 3-dimensional
Yes.
representation of,
Yeah.
of the dose. So there's going to have to be some interpolation.
There is interpolation. That is one of the, I think I got a slide for it here. We need to interpolate the data between 15 pieces of film. One that leads to a complication of the method, which is if we're trying to expand this to a QA analysis, we don't want it to be labor intensive or complicated, so that is one of the issues. It also means that it's just the software written is more complicated to write, which leads to more errors. So yeah, that is an issue. Potential modifications of the phantoms could be perhaps looking at a cubical phantom instead of a cylindrical one on a moving platform. It wouldn't be exactly the same as what's already been done, but it would, 1, allow for better interpolation, and 2, it means that one of the other problems is this film is different lengths because of the cylindrical nature. That's more interpolation because you're correlating this dose here to somehow try and get the dose out here for a square-shaped dose distribution. So
You could try different interpolation methods as well.
you could. That'll be something I have to look at, considering I'm not, I haven't even really started looking at the software needed because I don't have any results to really use it with. So that is something that I'm going to have to look at, but I'll probably ask you guys for it because I'm hopeless. Yes?
This may actually be a little bit lateral to that. Could you just go back to the slide with the X-ray?
That one?
The fiducials.
Oh, right, yeah. Yeah.
Is that 6 fiducials?
That is. I noticed that as well. It's unusual.
Yeah, so that's what I was going to ask. Do you know why? Because my understanding is often there's actually only one because of the risk of pneumothorax.
Yeah. So this is because this was part of a clinical study. So this wasn't. I believe it was part of a treatment, but it was also used as. They went out and intentionally implanted this many fiducials as part of a study. I did notice it. I picked this because it's the easiest to sort of see what a fiducial marker does. If there's just one in there, it's a bit hard to understand what it's doing. But yeah, that is unusual, and typically there'd only be about 3, maybe 4, in order to get that rotational correction. If they can get away with it, they'd rather use 1 because it limits the risk. But yeah.
I was just wondering if it was in a location or something that was easier to,
Yeah.
Yeah, you mentioned you're using the gamma analysis.
The gamma analysis, yeah.
Is that like the only metric or any big downside to that?
So the biggest downside for the gamma analysis is that it utilizes both geometric and dosimetric parameters to qualify a pass or a fail. But using just the pass or fail, using just the gamma analysis, there's no way to tell which one of those metrics is failing. So qualitatively, we can look at it and we can see if obviously the beam is aimed wrong. We can tell, okay, it's geometrically inaccurate. But just looking at the gamma analysis, we know it's a fail, but we don't know if it's a fail because the beam was aimed wrong or the beam wasn't giving the dose that we believe it to be. Typically, it'd be both, but it doesn't give us a full view of what's causing the inaccuracy. And the only way to really get that full view using this is to then perform some sort of qualitative visualization, something like an isodose curve or a visualization of hotspots on the data. But yeah, so it's not perfect, but it is a good quantitative way of measuring dose distribution relations. Yeah.
So you mentioned that fiducial markers have some have an associated error. They may move around.
Yeah.
Have you thought about ways that you may model that in your phantom analysis?
So there is a study that I looked at. I'm not sure if I included it in. Oh, it's not. Where's the literature review? It's one of these for the fiducial markers where they actually modeled the. Oh, yeah, here it is. With fiducial displacement. So they actually modeled the fiducial displacement using deliberately displaced fiducial markers in the phantom. Whether I'd account for that in the model I'm not entirely sure if that's applicable considering the already kind of breadth of it. We're already doing fiducial markers versus Xsight 1 versus 3 and no view, 1 view, 2 view, including another parameter of with fiducial displacement or not. That's doubling the number of measurements we need to make to really make that big comparison. And one of the other kind of limitations of this project is the method or time. It's 15 pieces of film for 9 treatment plans per patient breathing phase. So that's, math, 135 pieces of film per measurement. If you're increasing that anymore, you're starting to get into the one where you're really running into time considerations. But it's another aspect that we could really look at for future research.
Toward the end of your project, Brendan may have some results with gel, so you can compare them.
Yeah, we were thinking about that. I was talking about that before I actually picked the project, is that especially considering that we've had that recent gel dosimetry paper come out just this year, it does look like it could be a potential avenue for CyberKnife QA in 3 dimensions. It could be an interesting thing even just to compare the data and see do they hold up and what are the differences. So yeah, it's definitely a point of research that could be done.
So the other option we have for films, just imagine they can cut them like a circle using laser cutter.
Mm.
We are hoping to get that laser cutter, then put them in stack. It's really, really easy.
Okay.
Easy rather than this way.
Yeah, right. Yeah, that definitely cut down on time and let us do more measurements.
There'll be a little bit of waste of the film because film is expensive. But
Yeah.
because of this research project, we wanted to have a bit more robust, and you're not missing any information because it's all.
Yeah, right, because it's all stacked. Okay, yeah, that's.
much easier to
For the 9 plans, are you only going to deliver them once?
I believe so. That's what I think Thomas did in his initial one. But we're planning to deliver them once per patient trace. I believe one of the criticisms of the original proposal was the fact that it was only restricted to 1 patient trace. So ideally we'd be doing this over multiple different patient traces to compare them across. If we get the time, if that film cutting method does come through and time becomes less of a factor, we could definitely do more per trace. That gives us a more statistical certainty as what results we're getting, and then we can then compare those more statistically certain results with the other traces, and it just overall improves the study, I believe, but it will kind of come down to, I think, time and labour, I guess.
other questions? All good? Thanks very much.